You know, it's like, no. In a week, no. It's an unknown period of time, you know. Yeah, it was nice to ask, but I did come back with it and said, look, there's no provider. They're all suffering. They've all got capacity. Can folks hear me? Or I can, yeah. Either one. Okay. Thanks everybody for joining us today. It's such a pleasure to have Mike Dennis here. I think if one of the things that I said in my on Twitter is if I had to list the 5 addiction researchers that I learned the most from, that I most admire, Mike would definitely be in that top 5. And what he's accomplished with his colleagues at Chestnut is amazing. Mike is the director of Chestnut Health System's Lighthouse Institute and senior research psychologist, doing a ton of work. I will not give your full CV because I asked him beforehand. His mom's not on the Zoom, so we don't have to we don't have to give every detail. I will just tell you that this is Mike's CV. It is double-sided. It is 102 pages, and it is 300 academic publications. So, I don't know what to say, to add that, but just has he's just done so many things, not just peer review contributions, but also contributions to the community and serving vulnerable populations, showing incredible ingenuity during COVID and a kind of relentlessness working with city, county, state systems that really don't work very well and require that. And one of the real humbling things for me, as I've learned from Mike and his colleague Chris Scott and others, is just how to knock down walls to get stuff done for vulnerable populations that need that. And so with that, I'm going to shut up now, but I'm going to give you the chance to talk. And I'm really looking forward to learning today about recovery management checkups and SBIRT and related stuff. By the way, I should say, folks, if you have questions, please put them in the chat or in the Q&A if you're on Zoom. And also, I think Mike's quite happy to take questions from folks in the audience here.
Right. I'm here for you, so don't feel bad about interrupting. I'd much rather have questions, particularly we're on a slide if something's confusing or I use a term. I tried to spell out most of my abbreviations, but occasionally I miss one if I've done that here. Before I begin, I do want to acknowledge that, as you will see, I have based this presentation on the cumulative work of many of my colleagues, including Dr. Christy Scott, Dr. Chris Grella, and Dr. Dennis Watson, who has worked with some of you here before as well. Today, I want to try to give you some background on substance use disorders as a chronic relapsing condition with a high risk of relapse that require public health or disease models, to review the efficacy of RMC in prior studies and to summarize the main findings of where we've used it here. Just to give you a little bit of context, substance use disorders are widely recognized as a chronic brain disorder associated with loss of control, craving, continued use, in spite of social, mental, or physical health problems, and with a high rate of risk of relapse. SUD are consistently found to be one of the top 10 causes of healthcare utilization costs and of death. Untreated SUD and other mental disorders are also associated with school dropout, unemployment, involvement in the welfare and legal systems. Yet SUD are the only one of the 10 major chronic conditions where the U.S. has yet to invest even a fraction of the cost in prevention, early detection, intervention, long-term remission, and monitoring that characterizes a public health or disease management approach used on the other 9, like cancer, diabetes, hypertension, and so on. Today, only about less than 1 in 12 adults aged 26 or older are actually access treatment when they have SUD, and less than 1 in 36 adolescents with SUD access treatment. So there's massive healthcare gaps and health disparities, particularly by age. So let me start. I don't know how many of you have ever heard of the term screening, brief intervention, and referral to treatment, but it's likely that when you've gone to the physician in the past year or so, somebody asks you, do you drink? How many drinks do you have? If you say yes. Or have you ever used drugs? And if you say that, how often do you use them? You are being experted. It's screening and brief intervention, okay? The technical term inside of primary care is expert, but they're not going to necessarily tell you what they're doing. So let me just give you a little background on, on what this is. There's several different versions of this pyramid with multiple layers and stuff. I'm going to use one based on actual data. So this is from the National Household Survey on Drug Abuse. And each of those things represents, the bottom is about 60%, then 30%, then up to about 7%. They represent fractions of what you have. And the idea of screening and brief intervention, the theory was that this middle group, because it's 4 times the size of the substance use disorder population, targeting it with early intervention and some brief intervention would probably actually produce a bigger benefit than just focusing on after people had already developed a more severe disorder. Think of substance use disorders as like stage 4 cancer or something. You don't want to wait till it gets so bad that it's hard to treat. So the first point of screening is to get out of the way the 2/3 of the people that don't have a problem. So there's a large percentage of people that if you got there and you said, no, I drink a couple drinks, if you didn't answer 4 or more drinks on average when you drink, and if you didn't drink at least weekly in the past month or past 90 days, they're going to screen you out as probably not being important. They don't have to worry about this for you. On the other hand, if you identify as drinking heavily weekly or more often, or using drugs weekly or more often, or if you had even mild symptoms of substance use disorders, the beginning of onset, even if it's just 1 symptom, whereas 2 is diagnosis, that's going to trigger them to do a brief intervention. And research has consistently shown, actually, that when you identify, and particularly when a physician or someone you trust identifies that this is a problem and a risk to you, and they even spend 5-10 minutes giving you feedback, it actually is associated with reduced use and reduced problem use. So it's not a huge effect, but there's a real effect. And this has become so well accepted that the U.S. Prevention Task Force has recommended that it always be done in primary care, and the Office of National Coordinator of Healthcare, which is what regulates the Affordable Care Act, the person in charge of regulating it basically mandates it for all health insurance, which is why I'm pretty confident that all of you can ask those questions. The problem is that little triangle at the top. If you screen for substance use frequency and problems, you also find a group that has a substance use disorder. And what are you going to do about it? Because brief intervention, there's no way that it's adequate. That's like saying stage 4 cancer is diagnosed and is indicated by a screener, and you're going to say you should stop smoking. Kind of a little late, right? It's not an adequate intervention. So the idea is that they would add referral to treatment, or RT, which makes SBI SBIRT, that would help address it. Some of the other problems that came in with the model is that the assumptions that there should be a ladder, that you should see people with no substance use problem have no issues, moderate problems have moderate, high have high, turns out not to fit the data. You can see that within substance use disorders, but the brief interventions targeting high frequency, not high frequency, weekly use, or mild cases, turns out not to have any relationship to actually presenting for primary care. It does predict infectious disease, it does predict trauma, it predicts a variety of things, but not primary care needs. So by mandating to primary care people do this because it should lead to primary care problems, it runs counter to what they're seeing. in terms of problems. You don't have a problem with emergency departments or trauma units because they see the relationship. But in primary care, most staff are annoyed by having to do this because it doesn't fit with their experience. When I get off of healthcare and I look at mental health, if I look at missing work or schools, having problems in the legal system, violent behaviors, having 3 or more of these things, you can see that in every case, it is primarily being driven by those with SUD, not by the middle group. There is a little bit of relationship, but not a much. But those odds ratios for the last two, I mean, 3 or more of those problems, an odds ratio is 11. I get excited at 1.2. 1.5, 2.0, I think I got a good publication here, but 11 is bigger than a bread box. You can see it. It's pretty easy to show. From early on, as I mentioned, there's some of the problems here with SBI. From early on, it was clear that it was an inadequate response to SUD. Esper tried to address this by referring people to brief or regular treatment, but it was really created in the 80s when there were fixed lengths of stay, which the substance use treatment has completely gone away from, and now they want continuums of care and individualized lengths of stay. So the model assumes something that doesn't exist anymore. Across settings, the meta-analyses had shown that the referral to treatment part worked in trauma and ED, but it did not work in primary care. There was literally no difference between the control group and the Esper group on the singular referral to treatment component. They were not increasing anything over the spontaneous rate of people showing up to treatment on their own. There was also very limited focus on drugs other than alcohol. The original research all came out of alcohol research. And there was a couple of large clinical trials trying Esper for drugs, and they failed spectacularly. There were no effects again. Across settings, moreover, in the past 30, I mentioned the last one already there, sorry. So let me give you a little background on what RMC is. First off, it's not something radically new. It really builds on 3 things often used in public health approaches. Motivational interviewing, which is a way to help elicit a person to engage in their own behavior change. Linkage assistance, you think of these as peer navigators, pilot, different system navigators. Linkage assistance is common because our systems for services are complex. And the third is the idea of ongoing monitoring. When you get released after a heart attack, they don't say bye. They say, we'll see you in a month. We're going to see you in 3 months, and they're going to follow you up and monitor to track whether or not you're responding and if there's change and if there's a return of problem. Same thing with cancer, same thing with diabetes, same thing with asthma. Every chronic disease has, except for substance use disorders, has a hallmark of ongoing monitoring. The American Society of Addiction Medicine is coming out with their version 4 of their patient placement criteria, and for the first time this year, they are going to add a level of care for long-term remission monitoring. That's how recent this is. There's 4 main components. We call it, when we teach it to staff, we talk about it as a Taylor model, that in order to do RMC, you have to know how to do 4 things: tracking, assessment, linkage, engagement, and retention. For tracking, we basically took a follow-up model. LI is where I work is known for using Chris Scott's model of follow-up that pretty reliably gets 90% or more. Doesn't matter what kind of drugs they use, doesn't matter if they're homeless. We've gone out up to 19 years and still get 90%. It's just a very systematic way of doing it, but we pulled that in to this intervention model. For assessment, we built on the global appraisal of individual needs, or GAIN assessment tools that I've led the development of over the last 25, 30 years. And those range from 5 to 120-minute survey instruments. But we build in the components we need, which are really a core of about 5-10 minutes, so that we can do it either as part of a larger assessment or as just for the intervention. For linkage assistance, we use MI to get them to agree to go to treatment, the patients, help them with scheduling and transportation. We've negotiated in advance accelerated admissions to the most likely programs where we're going to be sending them. And then we also recognize that not everybody's willing to go to treatment at any given time point. And so we'll try to negotiate some kind of harm reduction or commitment to behavior change. We'll certainly refer them to self-help if they want that, but we'll also try to get them to move towards less risky use or low frequency use or something like that. We do not view it as sufficient for ourselves to make a referral or even to drive them over there and get them in the door. We actually continue to work with them for at least 2 weeks to ensure that they've reached the federal definition of engagement, which is 2 additional formal sessions in the first 30 days after admission. So we actually stay with them to make sure that treatment has taken hold. Usually if we can get them to engagement, treatment will keep them in. If we saw people who didn't reach engagement, there's literally no effective treatment. We actually did analyses to figure out what the threshold was for them to observe an effective treatment. Walking in the door and having an intake doesn't affect your outcomes. It's only when you get at least some modicum of care. We're also trying to reinforce retention because we're coming back quarterly or monthly and we're re-intervening with the person. It appears on. I can lean forward. Turned it up. Better? All right, I'll talk louder too. Tell me if I get too loud. Yeah. So for retention, we are trying to, when we do these quarterly reinterventions, we're trying to reinforce retention, continuing care. And I say continuing care because I don't care if you step up, step down, come back for a booster. I just care that the system is staying in the game with you, because addiction takes about 100 days before your brain has recovered half of its normal activity. So the idea that you can be in and out in a week is really not a promising approach. We also will do, if somebody's doing well, we'll reinforce their recovery. And if they're doing badly and they're out of treatment, we'll try to negotiate them to go back to treatment and accelerate their rate of readmission. I'm not going to try to go through all these studies, but over 2 decades, there have been research on RMC with 6 clinical trials and 2 quasi-experiments. There's some of the header pages there. One thing to know is we've done it as finding people in the community, trying to link them. We've done them trying to find them in primary care and link them to treatment. We've caught them at discharge, coming out of treatment, and tried to work with them. We have caught women coming out of Cook County Jail from Division 17 and tried to work with them. We've in general worked anywhere from 1 to 4 years afterwards doing quarterly checkups. In the longest study, we reduced the time from relapse to readmission by a little, just under 3 years. That's a pretty dramatic change for. Relative to services as usual, RMC is associated with higher rates of initiating care, reduced time between relapse and readmission, higher rates of engagement and continuity of care, increased days and duration of abstinence, reduced substance use disorder symptoms, and higher rates of being in remission, that is no use, abuse, or dependence while living in the community. There reduced HIV risk behaviors, reduced illegal activity, violence, and high-cost healthcare utilization. We've also collaborated with economists, Catherine McAllister and others, to look at the fact that RMC's cost is offset by these reductions in expensive healthcare utilization, pretty much breaks even in about 18 months. It comes out ahead as you go out farther. If you look at the cost of illegal activity, particularly violent crime, where you got assaults, rapes, other things that have huge intangible cost to the victim, it is wildly cost beneficial. So right now, what I want to do is pivot and turn and talk about the experiment that we just finished and the paper that's under review. But let me stop and ask on the background, are there any questions?
It says, how are harm reduction outcomes measured?
Reduction. So we look at harm reduction as if we can get them, it's a continuum. If we can get them more engaged in self-help, not just days of self-help, but their actual behaviors of, do they have a sponsor? Are they working the steps? Are they speaking up in meeting? Are they doing service? These are things that represent a higher degree of self-help involvement. We also look at changes in their use. If we see reductions in their substance use, or reductions in their needle use or needle sharing, or their reductions in their HIV risk behaviors, particularly trading sex for drugs and multiple sex partners. So this experiment was completed late last year, and we are currently, we've submitted it to the Alcohol Clinical and Experimental Research, which is the main journal for NIAAA that funded the grant. It reports on a 12 months, and as I mentioned, we have a range of other people who've contributed here. The three main hypotheses of this experiment are that relative to patients in ESPERT only, patients who also get RMC-PC will be more likely over 12 months to receive alcohol and other drug treatment. That's our primary outcome. It's a process outcome, some people may call it, but it's the thing we control the most. And it's the first thing that has to happen in our causal model. So that's our primary outcome. At 12 months and relative to patients in the ESPERT only condition, patients will also see typically less, more days abstinence, less days of alcohol, cocaine, stimulant, heroin, opioid, cannabis, and other drug use. There's also a summary measure called the substance frequency scale, which just combines those things and looks at them together. And then finally, the third hypothesis is that we believe causally that that RMC works by increasing the days of treatment. So if you pull in days of treatment, it should mediate the effect of RMC on those substance use outcomes. Running through these kind of quick. If I go too quick and you have a question, please don't hesitate to interrupt. Participants were recruited from 4 FQHCs in Chicago between July 2017 and March of 2020. As part of regular practices, these FQHCs were already doing ESPERT. We did provide them some training and feedback on what they were doing to try to make sure they were roughly similar. Those who met the patients who met ESPERT criteria for referral to alcohol or other drug treatment completed a form giving research staff permission to contact them. Research staff contacted these patients to explain the study to them, screen them for study eligibility, and if eligible, completed the informed consent and baseline assessment. Patients were then randomized to the control, which is ESPERT only, or the experimental. All ESPERT procedures were done by FQHC staff prior to randomization, and they would refer to treatment regardless of condition. All of the RMC procedures were done post-randomization only in the experimental group and only by the research staff. RMC-PC linkage to the original or subsequent treatment occurred post-randomization in both conditions. Sorry, that's what I just said. All participants completed a 1-hour research assessment with the GAIN Quick at baseline 3, 6, 9, and 12 months later after randomization, including urine screens during in-person interviews. In-person research interviews and consecutively urine collections were suspended on March 23, 2020 due to COVID pandemic, and all subsequent interviews were conducted by phone. Prior to that, we probably conducted less than 1% by phone in this study. Participants were paid $25 for each research assessment. Participation was voluntary, and the study was conducted under the supervision of Chestnut's IRB and a data safety monitoring board. In terms of inclusion criteria, they're actually pretty simple. They had to receive SBIRT from an FQHC, one of the participating ones. They had to score in the moderate to high range of either the audit or the DAST, which are ones for alcohol, the others for other drugs. They were eligible to receive a referral to alcohol or other drug treatment as part of a standard SBIRT procedures prior to randomization, and they were not already receiving alcohol and other drug treatment at the time they presented for primary care to the FQHC. So we couldn't reduce the time to admission if they were already in. For logistical reasons, we had several exclusion criteria. The study was just inside of Chicago, so if they lived outside of Chicago or planned to move outside of Chicago, we excluded them. If they expected to be incarcerated or in another confined environment that would prevent their participation, if they were under the age of 18, because we were linking to treatment agencies that didn't have adolescent programs, if they were court mandated to alcohol or drug treatment, which raises the bar for the control group, because the courts can force them. If they required an interpreter or language other than English or Spanish, and if they had a previous diagnosis of bipolar and schizophrenia. While I understand those could be adequately medicated, the agencies we were dealing with would not typically receive or deal with somebody who had more severe mental illness. And so you would send them to a different set of agencies. The planned sample size was 300 and designed to have 99% power for a moderate effect size of about an odds ratio of about 1.5. Due to COVID, the recruitment had to be stopped prematurely in March 2020 after enrolling 266 patients. The pandemic restrictions at FQHCs basically stopped all SBIRT screening because it was considered a prevention non-essential service. But treatment continued, so we were able to continue the study, just not recruit more people. After completing the informed consent and intake assessment, project manager assigned participants to condition using earned randomization with GRAND at about 50% per condition. Earned randomization was designed to ensure balance on several participant characteristics such as gender, race, age, referral type, as well as the level of SBIRT-based need and the site. This is an open trial, so both participants and staff knew what condition they were in. You know if you're getting recovery management checkups or not. The primary outcome, as I mentioned earlier, was days of substance use treatment. They were asked about the number of days they received treatment overall and by level of care, and then quarterly, and then this was used to sum up to make an answer for a 12-month value. In the small times when somebody missed an interview, we would take the average of the available interviews times 4. For descriptive reasons, we also asked them to tell us how many days they were in various levels of care. And then the cumulative days overall and by level of care were dichotomized for each time period. So did they get any treatment? Not just the days of treatment, that's got a lot of zeros in it. So we also looked at it both as days and any. And you see that when we get to the outcomes. Secondary measures including days of abstinence, which is positive when it's up, and days of specific substance use, which is positive when it's down. I'm not going to read through all these things, but they have relatively moderately decent size ICC. So who is most likely to use heroin in the future is somebody who's already using heroin. Who is most likely to use crack? Somebody who's already using crack. They have high interclass correlation coefficients over time, which is another reason why we're summing them over time. There were also, we used a protocol in which we would actually do an on-site urine test and give you the results before we ask you to talk about days. And then if you said you didn't use and your urine was today positive, we would say, whoops, I might have made a mistake today, but your urine was positive for cocaine, and it usually means you've used or been exposed to it in the past 7 days. Can you think carefully about the last time you used it, including if you used it in combination with something else? And then we try to get them to answer the question again. The reason for this is that while Urine tests are unbiased. They are relatively short windows. For heroin and cocaine, less than a few days. They're also dichotomous, so they don't give you very good measures of change. So we really want them to be honest about telling us about the days of using these things. So this protocol is designed to reduce false negatives and improve the rate of reporting, honest reporting on the variable of interest. As I mentioned, the substance frequency scale has a test-retest row of about 0.95 and alpha about 0.7. And that's just combining all these different types of days of use and problem use into one scale or metric. In terms of, if you think of a consort diagram and of the patients, 1,400 or so patients screened by the FQ8 staff, 350 appeared to need a referral to alcohol or drug treatment. Of those, they were considered potentially eligible. About 91% agreed to be contacted and screened. The main reasons why that 9% did drop out is that they, at the end of the study, they were outside of the treatment window. We never, or anywhere in the study, we didn't get through to them within a 30-day window after the referral. They did not consent to be contacted by the study team, so we never even had a chance. And then the active refusals was actually the smallest group, which was only 11, where they consented, talked to us, and then actively refused. Of those that agreed to participate, it was almost 50-50 exactly between the two groups, and follow-up were completed at 3, 6, 9, and 12 months, 91% or more of each condition waived, and 97% of cases had one or more follow-ups, so we could construct the outcome variable. Any questions before I transition to the rest of the results? Say that again? The rate of underreporting for substance use? So the false negative rate was about 2%, which is the percent that are positive on a urine that said they didn't use any days. So that's clearly an underreport. That doesn't mean that they didn't maybe use more days than they said they did. But they were at least giving reliable answers when we asked them twice. And relative to an objective biological measure, we had them down. We've had studies where false negatives can go up to 23%. Some studies published have had 50%. We've worked over decades to get it down to about 2 or 3% usually. Yes.
So if they did test positive for drug use, like if their use fluctuated, they were still eligible to remain in there. You were just kind of studying like how, like if their use might have been going down or something like that, like testing positive didn't make them ineligible.
Yeah, no, we don't kick them out for confirming their diagnosis.
Okay, yeah.
Their drug use is what we're looking for, and what we're trying to do is encourage honest reporting of the level of their drug use. So let me give you a little bit more background on some of the demographic characteristics. You can see about a third female, much higher rates of being Black and particularly age 50 or more. A Black sample from central to near western Chicago is not unusual, but this is one of the older populations I've seen in terms of almost half being 50 or older. And many of these people, this was the first time they were going to treatment. So it was a bit different than the typical drug treatment sample. If I look at their 90-day substance use characteristics, you can see that the 90% reported at least 13 or more days out of 90 using, which we call weekly use. There was referral to treatment is the higher severity in SBIRT, and referral to brief treatment is a lower severity. You can see it's about 2/3, 1/3. And then on the bottom, you can see about 78% we're screening positive in the past 90 days. They met all criteria for a substance use disorder, and then which disorders for alcohol and cocaine and cannabis were the three most common. A little bit of heroin and opioid use, about a quarter, and then very few other things.
In this group, especially for the older men, in some of our work, we're seeing really pretty high mortality.
I actually have to go back and look at this in JCoin. Normally in the household population for a similar age population, race, gender, get about 4.4 deaths per 1,000 person years. If you go to our prior drug treatment studies, we were looking at more like 11 per 1,000 person years. In our JCoin study, we're seeing 73 per 1,000 person years. So death rates have been going up, but a lot of this study was conducted pre-fentanyl, had not yet really taken the street as much. So I'm not sure. I'd have to go back and calculate it.
Low year 73 number in our hub as well. We have 4 deaths that we know of so far.
Right. No, it's that seems to be a consistent across the justice studies. The rates have skyrocketed. Even from, this is only 3 or 4 years earlier. It's not that much earlier, but fentanyl in particular has been driving it up. If I look at some of their other characteristics, you can see over 2/3 have mental health, physical health problems, stress problems, victimization or HIV risk behaviors, as well as a fair number with crime and violence problems. That's probably the lowest crime and violence problem I've seen because this sample is recruited from primary care as opposed to substance use treatment or justice settings. They also have around 40 to 54% have no past year employment. They had a history of being homeless in the past year, and they currently have no high school degree or GED. This is pretty bad, and in fact, 80% or more had 3 or more of these other things. So this represents a high rate of multimorbidity. So when you say, well, why do you really need this linkage assistance? If you understand that they have these chronic conditions, and then they have all these other conditions, their needs are complex and their ability to navigate complex systems are limited. So it's a kind of a logical rationale for it. Here are the main findings. I hope you can see that. I grabbed it actually from the journal. The histogram is showing the rate of any treatment for the 2 groups, with the lighter gray being the experimental. And then the dashed lines is the lines are the days of treatment. And what you can see is even at in the first period is baseline, and then 3 months, literally we doubled the percentage of treatment people getting into treatment in the first 90 days, and we doubled the days of services that they receive. If you look out further to 12 months, you can see that there's still while there's a diminishing return for each quarter, that continues to grow. So there's we've gone up to, I believe it's 26 versus 50 days. So again, we're almost twice as high. The rate of increase is slowing down, but it's still running about twice what the SBIRT only group did. The one thing this chart also shows is what's not there is even after 12 months of trying RMC with them quarterly, we couldn't get everybody to go to treatment. About 1/3 of the people did not go to treatment at any point in 12 months. And the reason that's important is it suggests the needs for some kind of harm reduction to be built into the component. That no matter how much we try, just not everybody's willing to do it. This is just looking at different types of treatment, looking at the various levels of care, and you can see that the majority of them, I believe this next one is just a picture of it. You can see that the majority of the additional care is coming in the form of higher levels of care. They're more likely to get residential IOP or medication-assisted treatment, whereas you don't see much different for generic outpatient or other services. So most of the effects are being driven not only by getting them to care, but getting them into higher levels of care. If I look at their days of substance use here, you can see that the days of abstinence, the black bar is the experimental, actually increased, which is good. And then in the bottom ones, you want it to decrease, and you can see reductions in alcohol, cannabis use are individually significant. Heroin is in the right direction, but not reaching statistical significance. And then cocaine is actually slightly in the wrong direction. And then substance frequency scale shows that when we combine these things, we get an effect size of about 0.25. Yes, sir.
In the chat, which I think maybe a question about the current time, but wondering about xylazine use, particularly since naloxone, Narcan do not reduce overdose. Is this something that you are starting to see more frequently, and would this be considered an other substance?
Xylazine is the new scourge of the existence. It's too new. This study, it comes completely after it. That really has been taking off in the past 12 months and spreading, and now it's getting pretty common. It is causing Narcan not to work as well. Doesn't seem to work as well with it, from what I've heard.
Reasons given as to why the participants would not accept treatment, aside from wanting LOC 3.5 or MMT/MET.
Yes, we did ask them about their barriers to treatment, their motivations for treatment, and sometimes they were willing to say that it made sense, but they weren't willing to do it right now. They had too many commitments. The schedule wasn't convenient. They didn't have a way to get there. They didn't have a way to pay for it. They didn't have a way to the transportation they needed to do it. Sometimes they had childcare or housing issues, particularly if they were homeless. It might not be adequate to go to treatment unless they could get residential treatment. This represents the direct effects in a path model. And you can see that as we hypothesize SBIRT, when we add RMC, it increases the days of treatment, it increases the days of abstinence, and days of treatment have a direct effect on days of abstinence as well. If I put those in a path model, then I get the last coefficient here, which basically becomes no longer significant. And that is a very, very conservative Behrman and McKinney type mediation model to say that it's completely mediated by treatment. So our focus has always been on our primary outcome on increasing treatment, because that's how we think we're going to cause the change. That's our mechanism of change. And so this basically just confirms that again. So the current study builds on these prior results by replicating the value of the initial RMC meeting and demonstrating the added value of 3 subsequent checkups. That may seem obvious to you, but right now for the state of Illinois, we do find people out of treatment drug users in the community and get them into treatment. And we've tried unsuccessfully for 3 years to get them to fund additional checkups. But the state says, no, get them in, and then it's the treatment agencies to worry about. So this was in part trying to show them the value of these additional sessions. As hypothesized, those assigned to RMC-PC were more likely to have intended any type of treatment, had more average days of treatment when compared to the SBIRT only. Additionally, RMC-PC was associated with significantly increased days of abstinence and reduced days of alcohol and cannabis, and lower mean scores on a composite index of alcohol and drug use severity. We confirmed through mediation analysis that the days of treatment was the primary mechanism of change in days of abstinence, with more days of treatment positively mediating. The results represent a major advance relative to the meta-analyses I mentioned earlier, that it showed no effect of referral to treatment. There actually are some effects of people showing up, but we've more than doubled those effects. It's also one of the first studies to demonstrate a positive effect of RMC-PC on reduced drug use, particularly cannabis. So none of the drug use studies with ESPERT ever showed an effect in primary care, but this one did. Further, the results demonstrate the utility, if not the necessity, of using an assertive model like RMC, along with repeated assessments and linkage meeting over time with high-need populations served by FQHCs. Couple of strengths. We had a rigorous experimental design, replication across 4 sites, high fidelity of implementation of the experimental intervention, low attrition from follow-up. I think I forgot to put in the slide, but basically of those who completed an assessment, we completed over 95% of the linkage meetings that were planned at each quarter. We also have low attrition from follow-up and used standardized and assessment and outcome measures. There are some important limitations, though, that we want to acknowledge. Linkage management staff were employed directly by the research team, making this primarily a test of RMC's efficacy and limiting our ability to generate the findings to conditions in which linkage staff are employed directly by the FQHC. Over half the participants came from one of the FQHCs and over 80% from 2 of them. This limits generalizability, but in odd ways, because not every FQHC is a big FQHC. So it includes some smaller ones, but it does skew our results towards the bigger ones. As a result of COVID-19, as I mentioned, participant recruitment and urine testing were halted, and delivery had to shift from previously in-person to primarily telehealth. Some next steps, we're currently conducting analyses of cost effectiveness and quarterly transitions. We've done a lot of analyses where we predict what's going to predict who's going to go into treatment or not, who's going to go into recovery or not, whether they come out of treatment, whether they're going to relapse or go in recovery, and who stays in recovery longer. And we're going to be doing that next. We've just completed a pilot study with Miles Squares Health Center to demonstrate the feasibility of having FQHC staff conduct the intervention. We will be submitting within a year a pragmatic trial to evaluate the effectiveness of training multiple FQHC staff how to use the RMC to improve ESPERT, where it will then be tested more in the real world, and also not just on treatment, but outcomes and cost effectiveness. And with that, I will stop and see if we have any other questions. Other questions? Stunned the crowd with all your because of the follow-up. We're just too.
I have a question here.
Okay.
What do you think? So I was reading about the housing first model, which is where they house people who have active drug addiction, as a way to for long-term treatment. Do you think, from your study, this is an effective way? Because recovering from addiction is not linear in most cases, especially if they deal with mental health issues. Do you think the housing first model is effective?
Yes.
From your studies? Thank you.
I actually was on the design of it and the evaluation of it, and know the findings intimately well. Dennis Watson is also a colleague of ours, has done, that Harold and I have worked with, has done some evaluations of housing first, and it is quite effective. It does still ideally link to a bigger system where you still try to push them towards more sober housing and treatment, but it is unequivocally not likely to work if you just want them to stop before you address the housing.
Thanks. With your study, obviously there were a lot of positive things shown, but then probably also a lot of room for like extra research and like other, like you said, like outside of just these centers. Where do you see the impact of this like going? And I guess I'm asking like, do you want this information to be seen by policymakers who like are going to implement policy like around better addiction treatment, or like more so do you want this information to get out to like health workers who treat addiction and like they could have better tools like in their practice, or both?
All the above. That's not, those are not mutually exclusive. Obviously, we've fought for 20 years to get long-term remission monitoring included. Next week, the SAMHSA will be releasing a Talk They Hear You national media campaign to push screening into schools and pediatric clinics using some of the same tools and trying to improve not just self-screening and self-management, but also self-referral connections. To empower parents and or individuals to do that themselves. Those are all sort of a systematic push to move us more towards a public health or chronic disease model. I tend to say recovery management because it's more positive. In our field, we like positive things better than negative things. So, but it's the same thing. It's trying to make a better management of the system.
Tempted to do the RMCs, we would not be as successful as you are because you just have a whole set of organizational capacities that you've developed. And I just wonder how do we capture and document and help people, if someone in St. Louis wanted to do this and they, what kinds of guidance would they need? They said, we totally believe your study, but we want to understand what's the blocking and tackling of doing this successfully. What are some pointers that you would give them?
That's really the purpose of the next study, is to figure out how to do that. What we have done with somebody in St. Louis, oddly enough, that's working with the Metro Transit System, who is a peer recovery coach. We had him up here and trained him on how to do recovery management checkups and gave him feedback. They have to learn first and foremost how to do motivational interviewing. There's lots of MENT trainers around, and we use the MIDI, which is the most widely used tool to understand how well you're doing it. And we basically train to mastery. You're not ready to go out in the wild until you're doing it right. And then with the linkage assistance, it's really a protocol driven. A lot of people, we actually generate, we call it a linkage assistance worksheet from the assessment. We generate a linkage assistance worksheet which walks through what you're supposed to say to the person. It's script, and it's going to walk through steps that they have to do, like are they willing to go to treatment, what's the ratings and things like that. And so we use a lot of things to use technology to support staff for their clinical decision making and things like that, and we use slightly different approaches depending on where they're at. And then but the original manual was 2003, and I have a 2009 paper comparing the first two experiments, showing how badly we did on the first experiment and how much better we did on the second experiment. You do learn over time.
Here at Crown, where we're training master's students, many of whom want to be involved with MI, want to help the population that's living with SUD. I wonder, are there things that we should be teaching our master's students so when they go out in the wild, they'll be effective in implementing these types of interventions?
Yeah, I mean, there's three or four things that are like really, really essential. One of them is motivational interviewing, because we don't always have good bedside manners, and we don't really understand how to motivate people to do things. And most things we have limited control. A second thing I would say is to understand the concept of multimorbidity and how many people you're working with really don't have one problem. They have a lot of different problems that interact, and they're not all the same. They need different things. In the river that runs through multimorbidity, the single biggest driver is trauma. There is literally nobody who should receive substance use or behavioral health services that are not trauma informed. They don't have to be trauma focused, but the therapist shouldn't make it worse. Right? And they have to understand how trauma interacts with not only their clinical problems, but their interactions with the system. If the system has burned them, if the system has ignored them and made their trauma worse, they may have great reluctance to do it. And they may need help to cope with the system and go through it. If I had to pick a couple of things, that's probably the biggest I would focus on. Yep.
I'm pretty loud, but I guess it's always good to wait for the microphone. I'm wondering, and maybe I missed some of this in the demographics, I'm not sure, if you could talk a little bit about access to service. So you have this great program about engaging folks in services and you know, trying to make them feel comfortable. But I'm curious about, you know, how many of the folks you're working with are on Medicaid, for example, or how they're being able to engage in the treatment and access it with this program.
So this study was conducted post-Medicaid expansion. So most publicly funded treatment will certainly bill Medicaid or other insurance, but they also still have block grant funds to cover people who do not have assistance. The one gap is there's often a period in the first 30 days when they may have limited access to transportation assistance. And we tend to help with that because in our first trial, basically we had no effect until we introduced transportation assistance and then all of our effects. So now we just build it in. They also have difficulty with scheduling. They have a hard time negotiating with the system to get an appointment that works for them, given not just their transportation, but personal and home needs. So we basically act as an omnibudsman to try to do that. We also act in a lot of times as an omnibudsman to prevent discharge. Let them bill for more than one service at a time. Because right now Medicaid says you can bill for an outpatient counseling for substance use, but then you can't have a psychiatric management case the same day. You can only bill for one thing one day because of the accounting system they set up, not because it makes any sense in spite of the multimorbidity. The rates are low and have been coming up, but they're still very, very low. Illinois largely wiped out its residential treatment system, and while I don't necessarily think everybody needs residential, we do need some of it. Illinois has seen a 60% loss in adolescent treatment beds and capacity of programs, in part because the rates are too low, and those rates are the adolescent substance use disorders have been stable or gone up, but the number of publicly funded slot programs and slots for adolescents has gone down. So you have, as I think I mentioned briefly, 1 out of 12 adults with substance use disorders enter treatment within the year. If you get to adolescents, it's 1 out of 36. Young adults is about 1 out of 24. If you get to a person with a opioid use disorder, it gets up for adults as high as about 1 out of about 80% will access treatment sometime during the year. But with kids, it's 6%. If a kid has an opioid use disorder, they will not get treatment.
Chicago.
Yeah.
And the transition team, I'm sure, is looking at SUD and mental health and saying, what can we do to raise our game as a city in these domains? And I wonder if our new mayor came to you before he demanded a recount, what would you advise that the city of Chicago do to improve some of?
Well, there's an old proverb about if you keep seeing dead bodies in the river and you pull them out, you got to go upriver to find out who's putting them in the river, right? And to me, the most insane thing is that we don't do more with adolescents and young adults. That makes no sense. When we could intervene when the effectiveness of treatment is the highest is when we do the least. Any other questions?
Any questions in the chat? There was one comment in the chat that says, that talked about how there's a need to help peer recovery specialists act as independent professionals versus captured by organizations that use them primarily to remedy other staff and role shortages, and there needs to be more of a formal infrastructure to assist peer supporters.
So the furthest ahead in that I know of is Colorado, which has developed a series of certifications. Several states have a peer recovery specialist, but it's like a dead end, kind of like one thing and you can do it. Colorado has 2 or 3 levels plus a supervisor level where they supervise their own folks. Peer recovery is unequivocally a strong asset to any intervention, but does require training and assistance. We have to do things to make sure that they're maintaining their boundaries because they haven't necessarily had the professional training. We also have to do a lot of safety things to protect them because they may be so dedicated that they'll put themselves in dangerous situations. It's also stressful when people don't turn around because no matter how much effort they put in, and we don't want to cause the peers to go into relapse. So they're an asset to the team, but they're an asset that has to also be supported adequately. So one more over there.
Would be curious, what are your thoughts on how to address that challenge? Because it feels like it's such a big one sometimes that you don't even know where to begin.
Sure. So literally next week, the Talk They Hear You is launching SAMHSA's attempt to address the health disparities for adolescents. They're targeting pediatric clinics, school-based health programs in schools, and parents. And they're trying to get them access to free self-screening and assessment, and then free referral management. We've linked them with 22 different federal partners to resources to help them do that. And then later this summer, we're coming out with a professional version so that a pediatric clinic or an SAP or a school-based health center could also manage a caseload with it and could track their patients and resources and use it to find what they need.
I think we may have achieved thematic saturation. So why don't we thank our speaker? And this is just amazing work, Mike. Thank you so much for coming. Please enjoy your lunch, and just thanks everybody for coming.